Hey, good morning.
Good morning.
Casey, how are you? Hector, what's up?
Good morning.
Dr. A, how are you doing today?
I'm doing real good. How are you, sir?
Excellent. A little cold here in Tampa this morning. Last little bit of cold before springtime. So it should be good golfing weather today. So today we're going to talk about another neat subject. A very, along the lines of getting our patients to get their research done on dentistry and to be educated patients. This is a great one for understanding how to make decisions on your treatment plan. And the whole concept of today, the idea is the classification in a standardized way of a prognosis. So I think in general, the public is used to the term prognosis, and sometimes it scares you, right? Mm-hmm. You think about prognosis for a medical procedure.
Right.
And it kind of makes me a little nervous right now. In dentistry, a little different because you can use a prognosis conversation in a very helpful way in making smart decisions. And we're going to talk about a prognosis in two ways. The first way that we're going to discuss a prognosis is kind of like a global prognosis of the overall viability of a tooth. In other words, the risk of a tooth needing to be removed.
Okay. Yeah, like a whole picture kind of.
Whole picture, and when we're doing a new patient exam, it's really what things boil down to. It's like teeth that have a good prognosis, we don't have to worry about those teeth. It's kind of like, we've got that under your belt, we're good. Mm-hmm. Let's look at the next level, which would be a tooth that has a fair prognosis. A fair prognosis means, pretty good likelihood, a low risk of needing to be removed. Mm-hmm. So a high likelihood you're going to have the tooth, but it's not perfect, right? It's fair. So it indicates that there may be some things that need to be done to move it to a good prognosis.
Mm-hmm. Yeah, might need some dentistry.
Mm-hmm.
Some small things.
And that is what you want to start to think about, is if you could move something from a fair to a good, it may be worth your investment.
Right.
Now, if you have something that has the next level of a prognosis, when you go from good to fair, is going to be what?
Guarded.
Guarded. So guarded means it would be questionable, not as predictable. Mm-hmm. In other words, it's questionable right now because of a number of reasons that we'll go into. And it would behoove you to invest in some dentistry, because if you didn't, you are going to have a medium risk of being lost, right?
Mm-hmm. Of losing that tooth.
Of losing that tooth, of having discomfort. Mm-hmm. What would the next level be?
Fair. Oh, poor.
Poor.
I'm going backwards. So the next one is a poor.
Poor, yeah. So poor doesn't sound good. A poor prognosis would mean a high risk of you having problems with the tooth or the tooth being lost. A high risk. And this is where it gets difficult sometimes, because sometimes knowing too much for the patient is difficult. When you need the guidance, the expertise, the leadership of your dentist to look at all the other external factors on if this tooth is worth investing into, right? So a poor prognosis doesn't mean you should take it out, because what prognosis would that be?
Hopeless.
Hopeless, right? Just like it sounds. Doc, what's the prognosis on this tooth? It's hopeless. And that is hard to say. But it's also a good thing to know, because you don't want to waste time and money going down a rabbit hole where you could use that money to increase the prognosis on other teeth and get that one out and look at ways to make it more predictable. Okay, so that's the overall view of the idea of a prognosis. And the classification, what's important, is it's a classification that is standardized it's not like we're just looking at it and say, Doc, what do you think this one is?
Yeah,
Kind of feeling poor on this one.
we're not guessing.
We're not guessing, and it should give you some help, should give you some predictability, some confidence that the decisions that we're making are really going to help you what?
Get to 100.
Get
with
to
your
100
teeth.
with all your teeth. That's
Yeah.
what it's all about. And so when we're having these conversations and we're throwing around terms, you can be part of that. Doc, why did you give this one a guarded prognosis? I'm not even having any pain on it. So why don't we talk about how we designate the prognosis? How does it break down? How do we make these decisions?
So when we look at a tooth and we're looking at the whole picture, we are looking at a couple different factors to make these decisions. And these are evidence-based decision making. So we're looking at the evidence. The first thing we're going to look at is the amount of bone around that tooth. So if you imagine a foundation, you've got to put enough concrete for that foundation to be stable. Same idea with the tooth. The part of the tooth you see in the mouth is the crown, but there's a whole root system, and that's surrounded by bone.
You hope.
So you hope, and that's what's going to help keep your teeth long term. When people say, man, my teeth are wiggly, I'm afraid of losing teeth, a lot of times they don't have the bone support around there.
Yeah. So how do you know how much bone?
So we look at the level, it's kind of like a plateau of a level of where the bone should be based off the crown versus root portion of the tooth.
From the radiograph.
Exactly, the
Yeah.
radiograph. Yeah, and ideally, like a good tooth would have 80 to 100% of that bone support.
Yeah, so just picture less of the tooth out of bone, the majority of the tooth in the bone,
That's right.
like an iceberg.
Yeah. The next thing we look at is the strength of the tooth itself. So we're looking at the part of the tooth you see, that coronal structure, how much of that is there. And ideally, a good tooth will have 80 to 100% of that structure.
Yes. So 80 to 100 meaning, you know, like when you're a kid, you get a little filling on the top of it, but you still have the majority of your tooth intact.
Exactly. A tooth that's had very little dentistry, small filling, or no dentistry at all, and it's a completely intact tooth. Then we look at the tooth from the nerve aspect, and this is a subject we're going to touch on, but just to kind of touch on it now, the tooth has that nerve through the middle of it, and we want to know, is it healthy? So does it have any infection, or is the tooth doing okay? And if it needs a root canal, is it something straightforward? Or if it's had a root canal, was it a good root canal? So all that has to do with a good tooth.
Right. So even if a tooth has a nerve in jeopardy, if we're looking at it and we know that it can be made healthy through nerve treatment or root canal, it may still have a good prognosis.
That's right.
Can you kind of go into when that's not the case?
When it's more complicated, let's say a big infection or the nerve, it's like an anatomy type of thing. When that's a little bit more complex, that might not be as straightforward or as predictable.
So you may put that into a guarded or a fair prognosis, and you'll have that conversation with the patient.
Exactly.
Okay. And
And
what's another category?
That last category is really the position of the tooth in your mouth. And so think about an arch. You have the top teeth, one arch, and the lower teeth. And so is the tooth positioned well in that arch? And then in terms of how your teeth come together, is it good in terms of your bite? So that's looking at the function of the tooth.
Yeah, because if the tooth isn't positioned well, if it's in malocclusion, it puts it at more risk for collisions. Or maybe a tooth that's tilted over, it's harder to clean.
Exactly. It can compromise the teeth next door too.
Okay, so now you're starting to get the idea of when we're looking at it, we're going through and scanning what is the bone like, what is the nerve like, in the bone around the tooth, what we call the periapical health.
Yes.
Is there any abscess there? Is there any infection in the nerve? How that tooth is positioned. Is it sticking up above the plane of the teeth? Is it tilted? Is it out of the plane of the mouth? Maybe compromising the amount of bone around it if it's out too far and it has recession around it. And
The tooth structure.
how much of the tooth is intact? Is there more tooth than man-made material, or vice versa? Is there more man-made material, which now falls in the category of a structural default? It could fail. The mode of failure would be the tooth would crack or the tooth would break at the gum line. And that is how we determine the good, the fair, the guarded, the poor, the hopeless. And then we get and triage this, right? So we have our A, B's, and C's, which we've talked about before. So, hey, a tooth that is spared, if you have a lot of other teeth that are guarded, you may put the guarded in the A and the fair in the B category.
Right, get to it later and focus on getting your A's done.
Yeah, you triage that. Or, teeth that are not positioned well, how could you improve the prognosis of those teeth?
If you can, move the teeth into the right position.
Yeah, I mean, nowadays what I talk about is, there's all kind of opportunities to get you back to where it is sustainable. Mm-hmm. So these conversations, the difficult conversations, as we kind of alluded to, are the teeth that have a poor prognosis, and the patient is kind of like, shouldn't we just take it out? It's easy to say, but the replacement of that isn't 100% guaranteed. So I always say I like to use that replacement card, the get out of jail card, as a last resort to know that we've exhausted all the energy that tooth has. I hate to give up on a tooth. So just because a tooth has a poor prognosis doesn't mean you shouldn't take action and do something about it. Mm-hmm. So again, those external factors, sometimes that's a game time decision.
Right.
We get in there. You just had a case yesterday. You want to describe that just a little bit?
Yeah, it's a tooth that had a crown on it, and it had a cavity underneath there. This is an x-ray. We can see that it has a cavity in looking at it. So we got to kind of open Pandora's box. We got to take that crown off. We got to look at what's underneath there and kind of see how deep that cavity goes. And so at that point, it's a game time decision. Is this something I can clean out, fix up, and get a new crown on there, or is it too far gone? And luckily, it wasn't too bad. Clean up the cavity, build that back up, and we can get a new crown on there. And that's ideal. We didn't give up on that tooth.
Right. So as far as the pulpal health of that tooth, mm-hmm. if you're trying to categorize it as far as risk again, what was that like?
The pulpal health was good. It had a root canal already.
Mm-hmm.
Okay. And it was a good root canal.
And it was fine. There wasn't any pathology.
Exactly.
What about the bone?
The bone was fair.
Mm-hmm.
Some bone loss.
Okay.
Not ideal, but it still had good support. The tooth was not wiggly.
And what about its position in the mouth?
That was good.
Yeah.
It's in the right position.
So what was the problem?
The problem was that cavity, the depth of that cavity.
So as the cavity got bigger, mm-hmm. the tooth structure remaining got less. So what would you say the percentage of the tooth remaining was?
30%.
We're right there on that.
Yeah, it's on the cusp. It's
on that cusp.
teetering.
What did you do to improve that, to make it stronger?
We have to build that back. So the cavity's soft, and that's what really is the soft stuff that we need to take out, and then you're kind of left with a hole that you need to build back.
What else did you do?
We put a crown on top of that tooth.
And you also went underneath the gum.
Oh, yeah.
So as you went underneath the gum, you got into new tooth structure.
That's right, grabbing onto safe, clean structure.
Yeah, and we call that a ferrule. Mm-hmm. So we got new tooth structure that was underneath the gum that now gives you more support. It's like new energy that tooth had that had not been potentiated. Mm-hmm. And so sometimes you can do that, sometimes you can't. If the decay goes too far out of bounds, in those cases, and that's the game time decision, you're looking at it and you're like, woo, there's 2 millimeters of tooth underneath that gum. It is going to be a little sore afterwards, but guess what? It improved the prognosis of that tooth, and it took it from 30% to maybe 40 to 50%. Mm-hmm. And so it's a very interesting way to look at the game time decision. In that conversation, was your patient involved in that conversation?
Absolutely.
Absolutely.
Mm-hmm.
Yeah, the patient kind of knew, you already knew ahead of time. And we're famous for this, is sometimes we over communicate to the patient, and sometimes the patient, I can tell they're looking at me and are like, well, you're the doctor. True, but in our style of medicine, we involve our patients in making that decision. Not everybody likes that, and that's okay, but we're gonna help guide you. We're your resource to help you make a good decision on that. So I think we did a good job of covering that. Now, there is another idea of prognosis. Can you talk a little bit about the other way we look at a prognosis?
So we kind of touched on the tooth in whole, but we haven't broken down this other part, which is just the nerve of the tooth itself.
Yes. So if we're going to do a procedure, let's say you have a tooth that has a filling. It's already had 2 lives. It had a filling, then when you were in your 30s, it got a bigger filling that involved the side and the top of the tooth, not just the top of the tooth like when you're a teenager or younger adult. And now that filling is starting to fail, got some decay underneath it, or the filling's cracked, or the tooth is starting to crack. Now you're on the 3rd life, the tooth needs a crown. So if you do the crown, is a nerve 100% guaranteed to survive that crown procedure?
Not necessarily, no.
Well, why do I do it then? I don't have pain. Why would I want to subject myself to have pain or to need a root canal? I don't have any problems with the tooth as far as pain goes.
Right. But we look at it and we're looking at that old filling, that bigger filling, and knowing it's failing. So we're trying to stay ahead. We're trying to do things that are predictable. So replacing that big filling with the crown adds strength to the tooth and keeps that tooth healthy long term. But there's a risk of that nerve, kind of like when you get a bruise, kind of getting bruised and bothered whenever we go in and touch a tooth. So
well, what if we didn't touch it? What's the risk there?
The risk is that tooth, that filling continuing to fail, getting a cavity or maybe even fracturing or cracking on you. It's can be a,
I mean,
a
so
bigger
if it has decay, it is technically infected, and that's not going to solve itself.
Right.
So it's not a matter of if, it's a matter of when it's going to need a root canal. So if you're going to go in there and intervene and arrest the decay process and crown the tooth, sure, there's a risk of a root canal, but you're going to make or break that tooth. And what's the key to minimizing the risk of the root canal?
Getting to things early.
Getting to it early. And we quote a statistic, at least we try to keep up with the statistic on how likely a tooth is to need a root canal in this scenario where the patient doesn't have pain and you're still a decent amount away from a nerve.
Right.
And what percentage of risk would you say is that a patient takes?
When we are having some distance from that nerve, you can be, let's say, 15 to 30% of a risk.
Yeah, it's closer to 15, but you're right, 15 to 30% risk of needing a root canal. Now, if a tooth, if the decay is a lot more extensive.
Right, we're getting closer to that nerve.
And we may say this tooth has a guard. Well, so first of all, the other category would be, in that case, 15 to 30. We would say you have a fair prognosis. If we say the tooth has a guarded prognosis, this should get your attention. And first of all, it should be decided ahead of time. So a guarded prognosis would be more like a 50% chance, which I tell the patient, kind of rolling the dice here. 50% chance in the literature that you can have a risk of a root canal. And we found ways to mitigate that risk with an anti-inflammatory protocol and keeping the heat down. You may wonder why the dentist is bombarding you with water, right? We're trying to keep the tooth cool to minimize that risk of pulpal death, right?
Right.
And then a lot of times we have to do heroic dentistry.
Right, yes.
Describe that. What's heroic dentistry?
Heroic dentistry is when we're going in and let's say cleaning out a cavity. We're throwing everything that we can at it. We're being careful how we're getting that cavity out. We're putting an extra layer of protective material to try to protect that nerve if we are close.
Yes.
And most of the times it's when we're really kind of building back that tooth where the tooth is maybe 30% actual tooth structure and the rest is man-made.
Yeah, and we actually get to the point where you can see the outline of the nerve, right? And so in those categories, it's more heroic. So we do something called a selective caries removal, And it's a protocol, again, backed up by literature.
Right.
And it's important to discuss because we talk to the patient and we say the chance of this tooth needing a root canal is pretty high. And of course, if it failed, the over the fence conversation with the neighbor was, why didn't he just do the root canal ahead of time? Well, because you can't discount the amount of teeth that make it.
Right.
And it's in our favor to take a protocol that's been researched and evidence-based to try to not give up on the nerve of that tooth. Because we would like to keep the nerve. And if you ask the patient, yeah, I don't want a root canal. But I also ask the patient, listen, are you somebody that wants to gamble a little bit? Because if this patient is traveling the world, sometimes some of my patients may say, Doc, if there's a bigger risk that it's going to need a root canal, I would rather do that preventatively. And that's a good conversation, right? It's important to know. And this is where the prognosis conversation comes really in handy with the patient.
Right.
We look at it ahead of time and say, this tooth has a poor prognosis of the nerve making it through this procedure. And the patient will say, well, just don't go close to it. Well, we don't have that option. We have to remove the decay. And if we can, it's a game time decision because the x-ray only shows you, it's like 30% worse in the mouth. So when we're in there and if we can see the nerve but it doesn't enter the nerve, then we call that an indirect pulp cap. If we can actually see the nerve and it starts to bleed just a little bit, now your chances go down, but it still has a chance. And that's a direct pulp cap. And that's typically where we're going to sit the patient up and say, your prognosis went down a little bit. It went from guarded to poor. How do you want to handle this? Like, okay, let's go ahead and do the root canal. So I think that you get the idea. There's a lot that goes into this. And I think the biggest thing is having that conversation with the patient, introducing the patient to this idea of a prognosis, and then making that decision together so that you can try to get some predictability. And now, as I say, we're kind of rolling up our sleeves and like we're working on this problem together, right?
Right. It's a team effort. Knowing the prognosis of the tooth gives you a better idea of what we're trying to do and also lets us phase out our A's, B's, and C's.
Yes. And it's not like the olden days where I'm the doctor, you listen to me, and you can't question my authority. That's never the way that we would operate.
It's a communication with the patient. It's a team effort. And that's why we explain things so much. We over-communicate.
At the risk of over-communicating now, we'll end.